This lecture will review hyperlipidemia from a clinical pharmacy and guideline-based perspective. We will discuss lipoprotein metabolism, the role of hyperlipidemia in atherosclerotic cardiovascular disease, and current evidence-based management strategies. Emphasis will be placed on risk-based treatment, statin benefit groups, and appropriate use of non-statin therapies. Hyperlipidemia is a disorder of lipid metabolism characterized by elevated atherogenic lipoproteins, most notably low-density lipoprotein cholesterol, as well as elevated triglycerides and, in some cases, reduced high-density lipoprotein cholesterol. From a guideline perspective, LDL-C is the primary therapeutic focus because lowering LDL-C reduces ASCVD risk in a dose-dependent manner. Severe hypertriglyceridemia is clinically important due to its association with acute pancreatitis. Lipids are essential for normal physiology, including cell membrane structure, steroid hormone synthesis, bile acid production, and energy storage. However, excess circulating LDL cholesterol promotes endothelial dysfunction and inflammation, leading to atherosclerotic plaque formation. This pathophysiologic process forms the basis for lipid-lowering therapy in cardiovascular risk reduction. Because lipids are hydrophobic and cannot circulate freely in plasma, they are transported as lipoproteins. These particles consist of a lipid core and an outer shell containing phospholipids and apolipoproteins. Apolipoproteins are critical for receptor binding, enzymatic activation, and metabolic clearance, making them central to both disease mechanisms and pharmacologic intervention. The exogenous pathway involves dietary lipid absorption in the gastrointestinal tract. Bile acids facilitate micelle formation, allowing cholesterol and triglycerides to be absorbed and packaged into chylomicrons containing ApoB48. These chylomicrons enter circulation via the lymphatic system. Lipoprotein lipase, activated by ApoC2, hydrolyzes triglycerides, and chylomicron remnants are subsequently cleared by the liver. In the endogenous pathway, the liver synthesizes cholesterol and secretes very low-density lipoproteins containing ApoB100. As triglycerides are removed, VLDL is converted to IDL and eventually LDL. LDL particles deliver cholesterol to peripheral tissues. Excess LDL contributes to atherosclerosis when taken up by macrophages, forming foam cells and promoting plaque development. High-density lipoprotein facilitates reverse cholesterol transport by removing excess cholesterol from peripheral tissues and atherosclerotic plaques and returning it to the liver. Although low HDL-C is associated with increased ASCVD risk, pharmacologic strategies aimed at raising HDL-C have not demonstrated cardiovascular outcome benefit and are not treatment targets in current guidelines. Lipoproteins vary in density, lipid content, and apolipoprotein composition. Key apolipoproteins include ApoB48 in chylomicrons, ApoB100 in VLDL and LDL, and ApoA1 in HDL. Recognition of these apolipoproteins helps explain lipid metabolism abnormalities and therapeutic targets. Chylomicrons transport dietary triglycerides, VLDL transports endogenous triglycerides, LDL delivers cholesterol to tissues, and HDL mediates cholesterol removal. Dysregulation of the exogenous, endogenous, or reverse cholesterol transport pathways leads to clinically significant hyperlipidemia. Hyperlipidemia is a major modifiable risk factor for ASCVD, including coronary artery disease, myocardial infarction, peripheral artery disease, and ischemic stroke. Other manifestations include xanthomas, xanthelasma, corneal arcus, non-alcoholic fatty liver disease, and acute pancreatitis associated with severe hypertriglyceridemia. Hyperlipidemia may be primary, due to genetic disorders, or secondary to medical conditions, lifestyle factors, or medications. Identifying and correcting secondary causes is essential before intensifying lipid-lowering therapy, as this may significantly improve lipid parameters. Common secondary causes include diabetes mellitus, hypothyroidism, chronic kidney disease, nephrotic syndrome, liver disease, and excessive alcohol intake. Medications such as thiazide diuretics, beta blockers, corticosteroids, estrogens, and atypical antipsychotics can also worsen lipid profiles and should be reviewed carefully. Lipid-lowering therapies include statins, ezetimibe, PCSK9 inhibitors, fibrates, and omega-3 fatty acids. Statins are the foundation of therapy because they consistently reduce ASCVD morbidity and mortality across a wide range of patient populations. Evaluation includes a lipid panel measuring LDL-C, HDL-C, triglycerides, total cholesterol, and non-HDL cholesterol. Non-fasting samples are acceptable for most patients, though fasting is recommended when triglycerides are markedly elevated. Secondary causes should be addressed prior to therapy escalation. In adults aged 40 to 75 years, 10-year ASCVD risk is estimated using pooled cohort equations. Patients are categorized as low, borderline, intermediate, or high risk. Risk-enhancing factors help guide treatment decisions, particularly in borderline or intermediate risk patients. Current guidelines define 4 statin benefit groups: patients with clinical ASCVD, patients with LDL-C greater than or equal to 190 mg per deciliter, adults aged 40 to 75 years with diabetes mellitus, and primary prevention patients based on estimated ASCVD risk. Therapy is guided by expected percentage LDL-C reduction rather than fixed LDL targets. High-intensity statins reduce LDL-C by at least 50% and are indicated in patients with clinical ASCVD or severe hypercholesterolemia. If LDL-C remains greater than or equal to 70 mg per deciliter in very high-risk ASCVD patients despite maximally tolerated statin therapy, ezetimibe is added first, followed by PCSK9 inhibitors when necessary. Moderate hypertriglyceridemia is managed primarily to reduce ASCVD risk using lifestyle modification and statins. Severe hypertriglyceridemia, defined as triglycerides greater than or equal to 500 mg per deciliter, is treated to reduce pancreatitis risk using fibrates or omega-3 fatty acids. Lipid panels should be repeated 4 to 12 weeks after therapy initiation or adjustment, then every 3 to 12 months. Hyperlipidemia management is risk-based and focused on ASCVD prevention. Statins are first-line therapy, with non-statin agents used as add-on treatment in selected high-risk patients. Lifestyle modification is essential for all individuals. Clinical principle: treat the patient's cardiovascular risk, not just the lipid number.